Hello everyone and welcome to the channel of Pharmacology where we not only teach but we also show you. हम सिर्फ आपको पढ़ाएंगे नहीं, हम आपको साथ में दिखाएंगे भी. So today's topic is bisphosphonates. Without further ado, let us begin in our discussion. So what do we mean by bisphosphonates? As you know, what bis stands for 2. Bis, it stands for 2. And phosphonate means that you have got 2 phosphate groups. So these 2 phosphate groups, they are attached to a single carbon atom. That means that the POP, this structure, in case of bisphosphonate, it will be something like PCP. And all the bisphosphonates, the suffix will be dronate. So the drugs will be known by the name, rather it will have a suffix dronate. Another thing to note is that bisphosphonates, they are divided into 3 generations. So these 3 generations of bisphosphonates, this classification is based on the potency as well. So the first generation of bisphosphonates that we have, the first generation of bisphosphonates will be less potent. The second generation of bisphosphonates will be more potent than the first generation. And the third generation of bisphosphonates, they will be the maximum potent bisphosphonates. And these bisphosphonates, they specifically target the bones which are undergoing remodeling. What does remodeling mean? Suppose when we remodel our house, what we do? Everything that is old, we change it and we make it into something new. So in case of bone remodeling also, what is going to happen? The old bone that we have, that will be replaced, and that old bone will be replaced by a new bone. And this is the process that bisphosphonates typically target. Now if you look into the structure of bisphosphonates, you are going to see, I have already told you, we have got a PCP structure, and if you will look into the structure, there are 2 alkyl groups also, right? R1 and R2. So based on what compounds are attached to this R1 and this R2, the bisphosphonates are also classified according to the generations. So the generations of bisphosphonates have been classified into 2, or rather their classification is based on 2 criteria. The first criteria is the potency, and the second criteria, or rather most important criteria rather, it will be the structure of the bisphosphonates, the group that is attached to the basic structure of the bisphosphonates. First generation bisphosphonates. As we have already discussed that the first generation bisphosphonates, they will be least potent, right? Also another point to note, that the structure, I have already told you that the differentiation of the structure, it also determines the generation. The structure will be the least complicated one. So the earlier structure, in case of normal structure of bisphosphonate, you had R1 and R2, and that R1 and R2 for bisphosphonate first generation is replaced by simple 2 hydrogen atoms. So the first generation bisphosphonates, they have the least potency as well as the least complicated structure. We also know that the suffix to the drug is dronate. See, dronate. So what are the first generation bisphosphonates? You have got etidronate, telludronate, melodronate and chlordronate. The second generation bisphosphonates. Now the second generation bisphosphonates, they will be more potent than the first generation ones. So in fact the second generation bisphosphonates, they are 10 to 100 times more potent. And also the structure will be more complicated than the first generation bisphosphonates. So now if you look into this structure, you are going to see that the second generation bisphosphonates, it will have a nitrogen atom attached to it. And the structures are also more complicated than the first generation bisphosphonate ones. The drugs which come under second generation bisphosphonates are Pamidronate, Alendronate and Ibadronate. Now moving on to the third generation of bisphosphonates. Now this third generation of bisphosphonates, they will be the one which will be maximally potent. In fact, third generation of bisphosphonates, they are up to 10,000 times more potent than the first generation bisphosphonates. Also, the structure will be more complicated than the second generation ones. So the third generation bisphosphonates, they also have a nitrogen atom, as you can see. But this nitrogen atom is present in a heterocyclic ring. And the drugs that we have for third generation bisphosphonate are Remodelling and Zoledronate. Now bone remodeling. Before we go into the mechanism of action of bisphosphonate, we have to learn a little bit about bone remodeling. Now bone remodeling, as I've already discussed, it means that there will be resorption of the old bone and in that place where the resorption of the old bone has occurred, in that place there will be formation of the new bone. So we are replacing the old bone with the new bone, right? This is what is happening in bone remodeling. In bone remodeling, you have got primarily the cells, and the cells are the osteoblasts, the osteoclasts and the osteocytes. Also, the hormones play a role in bone remodeling. But today for our discussion, we are going to limit ourselves to the action of the cells only. The hormonal part we are going to take up later on in some other lecture. Now the first cell that we are going to study today is the osteocytes. The osteocytes, they are the most abundant cell within the bone. In fact, an adult skeleton has around 90% of osteocyte cells. The second important point that we have to remember about osteocyte is that it helps in mechanotransduction. What do we mean by mechanotransduction? Mechanotransduction means that we are converting the mechanical stimulus into biochemical signals. That is what is happening in mechanotransduction. And these osteocytes, they form two connections. The first connection will be from one osteocyte to another, that is osteocyte connection, and the second connection is osteocyte to the bone cell connections. Now we have learned that the osteocytes, they are causing mechanotransduction. They are converting the mechanical stimulus into the biochemical signals. Now the question that arises is, what is this mechanical signal? Where from is it generating? Now this mechanical signal is being generated when a tendon is pulling on the bone, right? Suppose this is the tendon, this is the bone. So when a tendon is pulling on the bone, some shearing force will be generated, and due to this shearing force generated, there will be a mechanical signal. This mechanical signal is being transported by the osteocytes, and they are transporting it how? By converting it into the biochemical signals, right? So that means, suppose you have got one osteocyte here, another osteocyte here, and this is the osteocyte that is picking up the signals. This is the first osteocyte that is picking up the signals. Then it is going to transfer this signal to the second osteocyte. The second osteocyte is again going to transfer it to the third osteocyte. It is again going to transfer it to the fourth, and so on and so forth. That means there must be a osteocyte connection so that the signal can be propagated. The second thing, if you look into the internal structure of a bone, then suppose this is the central canal, and this is how the osteocytes will be located, one after the other. And suppose this is the surface. That means an osteocyte, it will also have a osteocyte to the bone surface. This is the bone surface. An osteocyte to the bone surface connection. This osteocyte to the bone surface connection, and there is a osteocyte connection. Now if you look into, this is a cut section. Now just imagine that you have got a whole array of osteocyte that is surrounding this bone, right? This entire region, suppose you have got only osteocytes, suppose something like this whole region, and you have got osteocytes here everywhere. Now these osteocytes, they are going to form ultimately a three-dimensional protoplasmic network. And with aging, this three-dimensional protoplasmic network deteriorates. Now if you look into another point, if you look into this diagram, then suppose this is a osteocyte, this is another osteocyte, this is another osteocyte. So in between the two osteocytes, there must be a gap so that the information can pass from one to the other. This gap is known as connexin. And the most common connexin or the most important connexin that we have is CX43, a potential MCQ. Now, as I've already told you that in bone remodeling, two processes are going to happen together. First will be resorption and second will be the bone formation. So the cells that help in resorption, it is the osteoclasts. These osteoclasts, they cause bone resorption. And these cells are hematopoietic origin cells. Now the second cell that causes the bone formation or the bone growth, that is the osteoblast. And these osteoblasts, they are mesenchymal origin cells. Now if you look into this diagram, these are the osteoclasts. So this is the internal structure of the bone. These are the osteoclasts. These cells that you have here, these are the osteoblasts. So these osteoclasts, they are what they are doing? They are causing bone resorption. And osteoblasts, they are causing bone formation. These cells that you have here, these are most numerous. So naturally these are the osteocytes. Now if you look very carefully, you are going to see that these osteocytes, they have got a osteocyte connection, and they also are connected to the surface of the bone, and there is a gap for the flow of the information. And what is this gap known as? We have already studied. This is the connexin. And the most important connexin is CX43. What is going to happen in case of remodeling? In case of remodeling, the first event that will be happening is there will be fusion of the osteoblast and the osteoclast precursor. So the osteoblast and the osteoclast precursor, they are going to fuse, and once they fuse, they are going to form the multinucleated osteoclast cell. This multinucleated osteoclast cell, it is going to attach itself to the bone, and the process of reabsorption or the process of resorption, it is going to start. Now we have studied that the multinucleated osteoclast cell, that is going to start the process of resorption. So now the question that arises, how is this resorption occurring? Now remember, for resorption, two processes are going to occur. From the osteoclast, there will be the release of the lysosomal enzymes. And what is the second process? There will be release of H plus ions. So these two processes, they are going to cause the resorption of the bone. Now due to the release of this H plus ions, the region where the resorption is occurring, this region will be acidic. So suppose this is the surface of the bone and an osteoclast is attached to this bone. So naturally it is going to cause release the lysosomal enzymes and the H plus ions. So now the surface of this bone, it will gradually be eroded. Right? The surface of this bone will be eroded. And this region, that is where this is occurring, this region, because of the release of this H plus, this region it will be acidic. Now the process where this resorption is occurring, it is in the bone matrix, and this bone matrix, it is formed by two major groups of constituents. The first group of constituent, it is the organic one, and in the organic constituents you have got the proteoglycans, you have got the collagen and the glycoproteins. There is also the inorganic component. This inorganic component, it is formed by the calcium phosphate crystals. This calcium phosphate crystals, they are also known as hydroxyapatite. So now, in the region where the resorption of the bone is occurring, in that region the concentration of calcium will be high because this calcium phosphate will be released. So as we have already discussed, that suppose this is the surface of the bone where resorption is occurring, and this is where our osteoclast is there. So this is the osteoclast. So now during the process of resorption, as you can see, there will be these kind of scooped out regions, right? These kinds of scooped out regions will be there. These scooped out regions that are occurring during resorption, they are known as the Hoship lacunae. And in these scooped out regions, there will be a high concentration of calcium, and also it will be acidic because of the release of H plus ions during the process of resorption. So now we come to the osteoblasts. These osteoblasts, they are the bone forming cells. So the Hoship lacunae that was formed, they fill up this Hoship lacunae with new collagen and new minerals. And ultimately the osteoblasts, they can have three fates. Now let us see what are the three fates of an osteoblast. The first fate is that it can flatten and become a cell of the bone surface. Second thing is that it can transform into an osteocyte. And the third fate is that it can undergo apoptosis and ultimately die. Right? Now the process of reversal in case of resorption is also carried out by the mononuclear macrophage cells. The mononuclear macrophage cells, they also help in the deposition of the organic materials that we have studied before. So now the remodeling of the bone, the cellular phase. As you can see, the quiescent osteoblast, they are activated when the osteoclast progenitors, they come and attach to it, and ultimately they are converted into multinucleated osteoclast cells. They are going to start the process of resorption. This process of, and there will be the resorption of the bone and formation of the hosi placunium. Now this resorption process, it will be reversed first by the mononuclear cells which differentiate into the macrophages, and also the osteoblast progenitors, they are going to differentiate into the osteoblast, and ultimately they are going to cause the deposition of the bone. And in this way the old bone, that is this old bone, suppose this is old bone, this will now be replaced by a new bone. So this is what is happening in case of the remodeling of the bone. Now why do we need the process of remodeling? The first point is that so that we can adjust the architecture of the body to the changing needs. The second point is that so that we can repair any damage that has occurred within the matrix of the bone. And the third point is that this also helps us in maintaining the calcium homeostasis within the body. So now the mechanism of action of bisphosphonates. The mechanism of action of bisphosphonates can be of two types. Now the first mechanism of action is for the non-nitrogen containing bisphosphonates or the first generation of bisphosphonates. And then there is a separate mechanism of action for the nitrogen containing bisphosphonates or the second and the third generation of bisphosphonates. So based on whether the bisphosphonate has got nitrogen or it does not have nitrogen in it, there are two kinds of mechanism of actions. Now the bisphosphonates, they have got a very high affinity for the calcium ions. And where can we find these calcium ions? These calcium ions are found under the osteoclasts, right? That is, suppose this is the bone surface, this is where the resorption is taking place, and this is where the osteoclast cell is. Then because of this resorption there will be release of calcium. We have already studied that. So naturally here the concentration of calcium will be high, and bisphosphonates have got high affinity of calcium. So now the bisphosphonates, they are going to be accumulated under the osteoclasts. And also remember, this region is acidic because of the release of the H plus ions. Now let us have a look into how does the first generation bisphosphonate they act. Now the bisphosphonates, they are accumulated under the osteoclasts, right? So this is where the bisphosphonates are. Suppose this is the osteoclast cell. Then this is where the molecules of bisphosphonate. Now these molecules of bisphosphonates, they will be taken up by the osteoclast cells. Now once these molecules get taken up, let us see what is going to happen. Now if you remember the structure of bisphosphonate, this was the basic structure, right? There is another compound within the body which resembles this structure, and that compound is the inorganic diphosphate. Now you know that ATP is formed from AMP by the addition of inorganic diphosphate. Right? Now you have got a large quantity of bisphosphonate that has been accumulated here, and it is being taken up by the osteoclast cells. So now within the osteoclast cells, the bisphosphonate will be high in number, and in place of inorganic diphosphate, this bisphosphonate, it will be incorporated. Hence it is going to compete with all the ATP dependent cellular processes. And now the concentration, since this is a competition, so now the concentration of bisphosphonates being high, naturally the synthesis of ATP will be low, because for ATP synthesis we need this, but we have got this. Now since the synthesis of ATP will be low, hence all the ATP related processes that are occurring, that are supposed to occur in the osteoblast, they will be stopped, and ultimately the osteoclast, it is going to undergo apoptosis or cell death. So this is how the first generation bisphosphonate they act. So now let us look into what is the mechanism of action of the nitrogen containing bisphosphonates, that is the second and the third generation of bisphosphonates. Now the second and the third generation of bisphosphonates, they inhibit an enzyme which is known as farnesyl pyrophosphate synthase. Now this enzyme, farnesyl pyrophosphate synthase, this is an enzyme of the mevalonic acid pathway. And ultimately through this pathway there is cholesterol synthesis. So since this enzyme is inhibited, then the synthesis of cholesterol, it will also be inhibited. Second thing is that these drugs, they inhibit the isoprenylation of the protein. Now the isoprenylation of the protein is important, by which these proteins, they attach themselves to the surfaces and then they are active, right? So since the isoprenylation of the proteins, that is inhibited, hence the proteins are not active. Hence since the proteins are not active, the response to the shear stress and strain, that is not proper, and because of this improper response to the shear stress and strain, the osteoclasts, they will undergo cell death. So due to the inhibition of the farnesyl pyrophosphate synthase as well as the inhibition of the isoprenylation of the protein, the osteoclasts, they undergo cell death. Another thing is that because it inhibits the cholesterol synthesis, this activity has also been linked with anti-tumor activity of bisphosphonates. Another very important and a potential MCQ. Now, as you can see from this image that the bisphosphonate, these are the bisphosphonates, they have been taken up into the osteoclasts. If they are non-nitrogenous bisphosphonate, that is the first generation bisphosphonates, they are competing with the ATP, ultimately there is apoptosis because of less synthesis of ATP. And if they are nitrogenous bisphosphonates, then they are inhibiting the HMG-CoA or the mevalonic acid pathway, and ultimately there will be decreased cholesterol synthesis. And because of the decreased cholesterol synthesis, there is apoptosis of the osteoclasts. Now the pharmacokinetics of bisphosphonates. The bisphosphonates, when they are given by the oral route, the absorption from the intestine is very poor. Hence, the bioavailability of this drug when it is given by the oral route is very low. Now students, we have got a detailed discussion on bioavailability and what are the factors that determine bioavailability. The link for that video will be given in the description box. Please do check it out. Now remember another point, the absorption of this drug, it is inhibited by food as well as by divalent cations. Now divalent cations like calcium, magnesium, ferrous. So they all inhibit the absorption. Now since food inhibits the absorption, hence this drug must be taken in an empty stomach. Another very important point to remember is that these drugs are primarily eliminated unchanged in the urine. Hence any patient with a compromised renal function, it is better to avoid these drugs. In fact, these drugs are not given in patients whose creatinine clearance is less than 30 ml per minute. We will not give these drugs to such patients. Now the adverse effect of bisphosphonates. The most important adverse effect of these drugs is that these drugs, they can cause heartburn, esophageal irritation or esophagitis. It can also cause abdominal pain and diarrhea. Now we have already studied that the bisphosphonates, their absorption is reduced by food and also by divalent cations. Right? And also the most common adverse effect is it can cause esophageal irritation, it can cause heartburn, and finally it can cause esophagitis. Hence, because of these reasons, some instruction to the patient is of very important. Right? So what are those instructions? Firstly, Since it is inhibited by absorption is inhibited by food, this drug must be taken in an empty stomach after overnight fasting and at least 30 minutes before breakfast. It must be taken with a full glass of water. Why a full glass of water? Because when taken with a full glass of water, the contact with the esophagus or the contact time will be very less, since the drug will go directly down. So to prevent this esophagitis, it is taken with a full glass of water, right? Now, this water that we are taking, it can be tap water, it can be filtered water, but it can never be mineral water. Why never mineral water? Because the mineral water, they already have calcium, magnesium and ferrous components within them. Even some foods such as tea, coffee and antacids, because antacids also have magnesium. Tea, coffee, because when they are prepared with milk, they have got calcium. So it is better to avoid them when you are taking the drug, and they must be avoided up till minimum 30 minutes after taking the drug, right? Another very important point to remember, that is the patient must be in an upright position after taking this drug, because if the patient lies down, then this means that is the motion of the drug going down, that is going to be less, and hence the chances of it being in contact with the esophagus, that is going to increase, and hence the chances of heartburn or esophagitis is going to increase. That is why the patient must be in an upright position after taking this drug, again for a minimum of 30 minutes. So students, each and every of these points, they can all be potential MCQs. So please remember this. These are very, very important points regarding the use of bisphosphonates. Now students, Pamidronate can cause a few characteristic adverse effects, but these adverse effects of Pamidronate will only occur when the drug is given by the IV route. And these adverse effects are skin flushing, flu-like symptoms, muscle and joint pain, nausea and vomiting, abdominal discomfort and diarrhea or constipation. And also remember that all these adverse effects, these are short-lived, and these adverse effects, they are not seen on subsequent administration of Pamidronate. A few characteristic adverse effects of Zoledronate are, it can cause severe hypocalcemia, and Zoledronate, it can also cause nephrotoxicity. Hence, prior KFT of the patient is a must in case of Zoledronate. Now a few of the very rare adverse effects of bisphosphonate, they are, it can cause osteonecrosis of the jaw, and bisphosphonates, they are also associated with stress fracture, and the bone that is most commonly involved is the femur, and the region is the lateral cortex of the femoral shaft. The drug with which this stress fracture of the femoral shaft occurs, the most common drug that is associated with this is alendronate. Now students, remember, this is also a potential MCQ. Now the contraindication of bisphosphonate. Bisphosphonate is not given in case of children and adolescents because we don't know the long-term effect of bisphosphonate on the growing skeleton. That is something that we don't know, right? Also, bisphosphonate is not given in patients who already have an esophageal disease, suppose esophagitis. If they have already active esophagitis, then in such cases we don't give the bisphosphonates, right? The most important or the most common use of bisphosphonate is in osteoporosis. Other than osteoporosis, this drug is also used in case of Paget's disease. It can also be used in case of tumor associated osteolysis and also in hypercalcemia that occurs due to malignancy. That's it for today everyone. If you like the video, then give it a thumbs up, also share it. Please do subscribe to our channel, since subscribing to the channel helps us in bringing you more contents like this. Don't forget to press the bell icon so that you don't miss out on any more upcoming videos. So see you again with more such videos. Until next time, goodbye and take care.